Hey, good morning, everyone. Thanks for joining us. My name is Rahul Patel. I'm one of the IR attendings here at Mount Sinai. Um, this is our monthly live case presentation from Mount Sinai. Joining us today is Chief of Interventional Radiology Services, I guess, is that what they're going to call you there? But Bulin Arslan from Rush Medical Center in Chicago. And then we have an interesting case. So I'm going to throw it to Lookstein, Dr. Lookstein, in the lab, and have him present the case.
Good morning. Can you see me?
I can see you. See all of you.
Fabulous. Okay, so I want to welcome everybody. Rahul, thank you for the introduction. I also want to thank a very, very dear friend of Mount Sinai IR, Bulin Arslan, who is the chair of interventional radiology at Rush Medical Center in Chicago, for joining us this morning. Bulin, thank you for supporting our educational efforts here at Mount Sinai. It's a absolute pleasure for you to join us. So sincerely, thank you. I wanted to take just a brief moment to thank everybody who's helped us get this case started and who's helped us over this calendar year to make Treat Live a enduring process. I want to thank our anesthesia colleagues whom without their support we could not get these cases done, and obviously most importantly they're keeping all of our patients safe, and so we're just so grateful for their partnership every month, every week, every year. So thank you to all of our anesthesia colleagues. I want to thank all the nurses that help us here at Mount Sinai. We have an incredible nursing staff. I would argue that the best nursing staff for interventional radiology in the world right now. I want to thank BroadMed AV, who's our AV support staff. They have been incredible partners over the years, and I can't thank them enough for helping us and supporting us in this effort. They are really just a 5-star partner for all of our educational efforts. And then last but not least, this is National Radiology Technologist Week, and I want to thank all of our techs here at Mount Sinai IR. We absolutely, without any hesitation, have the best interventional radiology techs in the world. They are top-notch, and they are just so selfless in their dedication to our patients. And so from the bottom of my heart, I want to thank all of them for such just incredible work year over year. I'm so honored to work with them every day. And again, without their help, we couldn't put on these educational efforts every month. So to all the techs, thank you so much. I'm joined today by a great team. To my right immediately is one of our senior residents who's going to be graduating in June, David Bamshad. To David's right is one of my colleagues and partners, Karema Garcia Reyes, who I think most of you know. And then to Karema's right is one of our rotating medical students, Michael. So we have a great team, and I think this is a fantastic case. David has put together a brief presentation to introduce all of you to this fascinating case, and then hopefully we'll get into some very interesting conversation about case management. So David, please take it away.
Hey everyone, I'm David. Welcome to Treat Live. So our case today is a 37-year-old patient, otherwise healthy female with a previously treated congenital left hand AVM. She's presenting with left hand pain and swelling. She actually originally presented in 2011 with a painful pulsatile mass in the left thumb thenar eminence region, and she was diagnosed with an MRA. I have a picture over here on the slide, but it basically showed this about 4.5 centimeter AVM in the left thenar eminence with rapid AV shunting. So we brought her in for a diagnostic left upper extremity angiogram, and you can see here on the right with the cine loop that there is a large AVM over there that's really kind of taking up most of the supply, and there isn't much distal flow. So we did a diagnostic first to try to get an idea of exactly the extensive of the the inflow vessels, outflow vessels, and maybe make a plan to discuss with the patient in the office on how to move forward in terms of treatment options. So we brought her back in 2012, not too soon later, and over here you see that this is the original angiogram. with a still image in the middle, in the center, showing the flow. And you could see these two large hypertrophied vessels, multiple vessels, but two main ones that are the arterial inflow into the nidus. And on the most right-hand side is our post-embolization image. We used Onyx liquid embolic, and we embolized the more lateral of the two vessels. The next slide, this is a post-embolization angiogram, and you can see that there is significantly, dramatically increased flow to the rest of the hand after embolization. She came back for a second procedure a couple months later, approximately 6 months later, and we did another angiogram and to select which vessel to go after next. We ended up taking and embolizing a more lateral vessel along the thumb, and you can see on the right is a post-embolization image. And next slide. So you can see post-embolization, the run still shows preserved flow to the distal thumb. That's something that we consider, when doing these embolizations, is wanting to make sure we don't cut off any other vessels that are, supplying the distal fingers. And she ultimately came back for the third treatment in March of 2013, where we ended up getting into this more medial vessel that was flowing into the nidus, arterial vessel. And it did have some distal supply, but we got distal into that vessel. Next slide. And we found a safe place to inject. This time we used glue. And this is the post-embolization run where we showed, again, preserved flow to the thumb. And after this, next slide, she had significant pain relief and was lost to follow-up. She was scheduled for office hours, but ended up being lost to follow-up. And now she's representing to our office hours after 11 years with recurrent symptoms for the last 3 months. She's presenting with the swollen left thumb, painful wrist, and engorged veins tracking up the left forearm, compatible with venous hypertension. So we're bringing her back today. Basically, in terms of assessment, 37-year-old congenital left-hand AVM, 3 prior embolization treatments, approximately 11 years ago, and now she has recurrent symptoms compatible with ischemic steal syndrome of the hand. So our plan now today is to proceed with another angiography and embolization of target vessels that we find, and we'll monitor her response to the treatment in office follow-up.
So thank you, David. Great presentation as always. I want to share with you what we've done so far. And we could talk about whether or not a patient after 11 years should get cross-sectional imaging or go straight to angiography. We elected to go straight to angiography. Just of note, this patient has been seeing me for the last 13 years. In my office hours. I was disappointed that she was lost to follow-up back in 2013, but again, as her pain recurred, she sought me out and showed up to my office hours, as David stated, about a month ago, and I spoke to her, and she really did complain of significant pain along her thenar eminence, and because she's been through this before multiple times, we elected to just go straight to angiography, but certainly worth a conversation. So we have a right common femoral access. We have a 5 French sheath in. We have a 4 French Aqua Tempo Vert diagnostic catheter that is hubbed in her left radial artery, almost at the wrist. And again, I'll show you some of the angiograms. The first angiogram we did was from the brachial artery, and you see this very significant arteriomegaly of certainly the radial artery, and I think what we're going to call the interosseous artery here. And you see, again, this extensive shunting. This is a selective of the interosseous, and this is a selective of the radial. And you see, obviously, extensive neovascular formation with this, now chronic AVM. Interestingly enough, the perfusion to the 2nd, 3rd, 4th, and 5th digits is preserved. And then obviously we've been working off camera to try and identify an appropriate feeder to try and embolize this again that will not compromise the circulation, most conspicuously to her thumb, to her first digit, but then obviously to not provide any non-target embolization for her index finger as well. Right now, we're fairly distal into the radial artery, as you can see here. And if we could just play this through, you can see we're in a pretty dense area of the nidus. I do not see any vessels that are giving distal perfusion to the thumb or to the index finger. And we're talking about which embolic to use and sort of how to set up the case. But I figured now is a good time to, get Rahul, you and Bulin back in to sort of talk about what the treatment options are and how you would approach a case like this.
Should I jump in?
Yeah, of course. Go ahead.
Absolutely.
Thank you for the invite, number one. This is an amazing event you guys are doing this. I'm so impressed, I can tell you. I also taking on such a complex case. That's also very brave. And good luck with the case, by the way. So I think you have done exactly what I would have done initially. Because it's a very tricky location. Obviously, you don't want to get a hand ischemia and amputation in these cases. One alternative agent I always consider in these aggressive cases, alcohol. Obviously, a lot riskier, but more effective. I usually have that discussion with the patients, saying that the ischemia is higher, but it may come to that if it keeps recurring. So what is your opinion? I just want to see what you guys think, how you guys approach, if that should be an option for this patient, or you feel like you can kind of tackle it further with gluononics.
So that's a great question. Personally, I have not been enthusiastic about alcohol in what I'll call superficial lesions. And I think that if you're working, for example, deep in the thoracic cavity or deep in the abdomen or in the pelvis, it's a little bit more tolerated. My greatest concern, and I had in full transparency, I did have what I would consider an adverse event when I started doing these cases maybe 20 years ago, where there was extensive skin necrosis in a superficial lesion and skin sloughing. And I had to have the patient involved with plastic surgery and aggressive wound care. And that was, I would say, one of those cases that so-called scared me straight. And I have really been enamored with, liquid embolics for these cases. Really for the last 20 years, I've been very, very honored and, privileged to collaborate with our neurointerventional colleagues, which in general have a little bit more experience with liquid embolics than I think peripheral interventionalists do. And then I'd be remiss if I didn't give a shout out to one of our esteemed faculty in neurointerventional, Alex Berenstein, who I've had the pleasure of working with for the last several years, who's really been one of the pioneers with the use of liquid embolics for pediatric congenital AVMs. And so we've just been, I'd say, very, very comfortable using liquid embolics over the years. And I think that's where we settle out with these, what I'll call superficial cases.
Excellent.
I sort of agree with Rob. We've had sort of I wouldn't say bad luck, but bad outcomes with alcohol in superficial space. I think the other thing to really point out is I think you have to make sure your treatment sort of aligns with what the patient's goals are. So if I have a patient that comes in and says, like, I'm not really that symptomatic, but I just want it gone, like, we're not going to really be able to make it gone, right? But if you're like hand claudication, then we can sort of do what Rob's done, is just sort of trim it in stages to try to get it down. And then you have patients that come with true digital ischemia and wounds and stuff, and then the treatment algorithm becomes a little bit different. So I think seeing these patients and sort of aligning our treatment abilities with their ultimate goal is also super important.
So I think Rahul is bringing up a very, very good point here. And, I met this patient when she was in her late teens and early 20s. And I think there's many people, just as an idea, would have said, she's got steel pain, ischemic pain, she should get an amputation. And I obviously don't agree with that. But now we're, 11 years later, 12 years later, and she has a functional hand, fully functional hand. We have not compromised the circulation to any of her other digits. And she's been pain free for the better part of a decade. And so I think it's a sort of a choice of what philosophy you want to follow. I'm not saying that this is 100% always right, but I think we've been able to take care of this patient's symptoms very, very well. And I think she values the fact that we've been very pragmatic with her about realistic goals. And she's very, very grateful that she's been able to maintain the use of her left hand for the last, again, 10, 11, 12 years.
So, and then if I may ask, just as a follow-up question, what type of onyx or glue will you be using? Low viscosity versus, which I assume low viscosity is going to be a better option in these cases, but what is your approach?
So I think that you can approach this with a lot of different techniques. My own personal preference, which I'll go through this in just a moment, is going to be pretty dilute glue. And I'll explain that in just a moment. But to kick this back to you, Bulent, and this is great conversation. I absolutely do not think there's one right way to do this. But at your institution, when you see these cases, what is your preference? I know these cases are obviously rare. I clearly value the opportunity and the privilege of presenting this as a teaching case, but I think it's obviously important to recognize there's more than one way to tackle this. So we're going to set this up to use very dilute glue, and I'll go through the setup in a moment. But just curious, in Chicago, where you practice, how would you choose to set this case up? Would you use ethanol, or would you use a liquid embolic? And in that instance, which liquid embolic would you use?
I think Rahul had an excellent point. I'm going to kind of reemphasize that what patient expectation is and what the goal of treatment is really important, and how aggressive you want to be. Let's say if this was painful, etc., and then patient suffering, almost considering amputation, because those things can happen with lesions like this. And if you're at that stage and I have 2 failed treatments, not in 11 years, like that's, I will not consider that failed. That's just kind of time that it required for it to come back. But I tried it, let's say 3 months ago, 6 months ago, patient is still not doing well, then I would consider alcohol in a very asymptomatic patient. But in this case, I'm totally with you guys. I would go with a liquid. I don't use glue as often. I switched kind of to Onyx EVOH long time ago, and I would probably use the low viscosity version, which is kind of correlates with the dilute glue, like you're doing. And then I wish we had even lower viscosity EVOH, which is available in Europe. That would have been a lot better option for us if it was here. But I'm with you. Very dilute glue is an excellent choice.
So when you do, so when you use, we'll just say, so lava 18, would you set it up with a balloon or some sort of flow modulation, or would you just go ahead and inject?
No, I'd rather have it go distally with the flow, because flow assists for distal penetration. And with the balloon flow modulation with the balloon, I think you may not penetrate as distal. And that's the goal here, right? Let it be dilute glue or low viscosity. You want it to get into the nidus. You want it to be as close to the capillaries, so you kind of solve the problem and prevent collateralization down the road, if possible.
Absolutely.
Yeah.
Absolutely. So I'm gonna start to get started here, because I think there's a couple of themes that I want to emphasize. One is that by no means do we believe that we're going to cure this morning. We want to debulk it in a way that is, very, very sensitive about patient safety. We don't want to change the flow so dramatically that we create more problems than we can. And then we want to bring her back in a relatively short interval, whether it's 2 weeks, 4 weeks, and sort of tackle this again. And the goal, again, from my point of view, it's really palliation. It's to alleviate her pain and allow her to maintain function of her hand. All right. So I'm going to show you where we are right now, and I'm hoping we can do maybe 2 injections in the remaining time that we have. So I have a microcatheter. This is a 155 True Select from Boston Scientific, which is really, in my opinion, a great microcatheter for these cases. You can see it, just going into the digital branch, supplying blood supply to the thumb. You obviously can see all the onyx that was deposited in this patient, again, over 10 years ago. And I'm just going to do a diagnostic angiogram so you can see the flow dynamics. And then we're gonna change this up just a little bit, and I'll share that with you in just a moment. So here's the real-time angiogram from the microcatheter that we have. All right. And again, I think that based on the intensity by which I was injecting, we're not seeing any reflux into any vital critical digital arteries, and that's a very important concept. If I were to see that, I would likely reposition the microcatheter into a different location. So now what I'm going to do is I'm going to ask our staff if they could turn on a tourniquet on her forearm. And the reason for that is obviously to slow down the venous return or the venous shunting. And the goal is to minimize the amount of the glue that transports through into the deep venous circulation, and to hopefully allow greater penetration into the nidus. In addition to that, we've given the patient Toradol. We're likely going to give her steroids in a little bit, probably off camera, to reduce the pain from likely the small collaterals that are going into her metacarpals, but essentially that's the concept here. We feel like we're in a very good spot to be able to deliver the glue and not have too much collateral damage. So the tourniquet's been up for about 25-30 seconds, and I'm going to try and repeat the exact same injection and just try and show you that whether or not we feel that there's, again, slightly slower venous shunting and venous transport.
So, Rob, where is the tourniquet on her arm?
The tourniquet is just below the elbow crease.
Okay, so in the forearm.
All right. Yeah. So again, I know it's subtle, but I think that hopefully you agree there's slightly slower transport of the contrast from the arterial side through the nidus into the venous side with the tourniquet up. And again, it's not that there's complete flow arrest here. That's not what we're trying to do. We're trying to avoid reflux. We're trying to be just proximal to the nidus so we can have antegrade flow. And we're going to inject the glue in just a moment. And I'm going to pause here to see if anybody has any questions about how we have it set up.
That's an excellent setup.
Yeah.
And you can see the venous flow is definitely slower, more stagnant towards the end.
Yeah.
Just give him one.
So obviously, since we're injecting NBCA, now I'm going to flush the microcatheter with D5 water. We prepared the glue off table, off camera before we went on camera. For me, dilute glue, and we were sort of joking around a little bit. Should we go 7-1 or 9-1? Karema felt 7-1 was better. I felt 9-1. So we decided, as we always do, to compromise, because we respect each other's opinion. And so we have 8-1 now. All right. And so, and again, I share that not to be silly, but to just show there's really no exact way here. And I think I'm going to learn a lot from this injection, hopefully, and we'll be able to either, modify this or change it moving forward. All right. So I'm going to start to inject the glue now. And, hopefully you'll see it transport through. And I'm injecting it very slowly, very gently. You'll start to see it escape the microcatheter in just a moment. There it goes.
Beauty.
And you were just about to get reflux, and we're pushing it through. Obviously, you're seeing nothing's going distal whatsoever. And I know this is masked, and some people would use a double reverse mask, but I don't feel that's necessary here.
Rob,
And
I know
basically, we have stagnation here. Go ahead, Bulent.
I was gonna ask, could you also go over for people who don't use glue, like what do you mean by 1 to 8, 1 to 9, and then
That's a great
tantalum versus
question. Thank you.
brittle?
So I don't use tantalum. I have injected. We have mixed off camera 1 milliliter or 1 cc of NBCA, and we have included in that mixture 8 milliliters of ethiodol. And so we are diluting the concentration of the glue instead of 1 to 1 or pure, to dilute it down to make it more, again, like a liquid and less concentrated. And the goal here is to create a larger volume. As hopefully everybody on the camera knows, this has a localized inflammatory effect, and as it penetrates into the nidus and into the substance of the AVM, it essentially will close the vessels down. What I'm going to do in just a moment is I'm going to remove the microcatheter, and I usually will do this fairly aggressively in an attempt to prevent from gluing the catheter in. Everyone sort of jokes in the lab about how aggressively I take the microcatheters out, but I'm sort of wrapping my hand around it almost like I'm pulling the cord on a lawnmower, and I'm going to just very, very rapidly. We're live on fluoro, and you'll see there the microcatheter came out. And there we are. All right. And so the glue didn't move at all. And I have a flush attached to this diagnostic catheter. Can I have a 10 cc syringe of contrast, please?
Rob, if I may just add something
Go right ahead.
in terms of the glue, since we're talking about how to dilute it. It seems, a lot of people who are starting to use glue get really scared about this concept of the microcatheter, getting stuck. And it seems like you waited, you were patiently waiting for a little bit. Can you talk a little bit about that?
Sure. So obviously we just did an angiogram, and you see that blood vessel that I was in was significantly debulked. Obviously, there's still perfusion distally, not only to the first digit but also to the distal tuft of the thumb. So we didn't compromise any distal circulation whatsoever. And there's basically like almost a big hole in the middle. So we're going to choose another feeding vessel right now. We obviously have a lot of glue off the side of the table. We'll probably do 2 or 3 more injections here while we're on a camera. To Karema's point, the concern about gluing yourself in, I think that the more concentrated glue that you have, you need to be concerned about it. Also, the more glue you have that's sort of touching the tip of the microcatheter. If you noticed on the previous run, we were fairly proximal to where I would call the nidus being located, and that allowed the glue to essentially travel distally, penetrate into the nidus, and avoid it really touching the tip of the microcatheter. That is a great way to avoid gluing yourself in. And then in these instances where you're dealing with very, very small vessels and you're not able to be that far distal, again, the more dilute that you are able to make it, the less likelihood that you have of gluing yourself in, and the more time that you have. As a general concept, we use 3-to-1 dilution when we're dealing with acute hemorrhage, GI bleeds, pseudoaneurysms in the viscera, inferior epigastric bleeds, and we feel very, very comfortable leaving the microcatheter in after the injection is stopped for a minimum of 30 seconds. We have a clock in the room so we can all keep track of how long we're leaving it in. For an 8-to-1 dilution, you have more than 90 seconds, almost 2 minutes, to allow it to stabilize and make sure it's not refluxing.
Can we take the tourniquet
so
down?
Those are all very important concepts. And yes, thank you, Karema. Can we take the tourniquet down, please? So we're going to send out a second microcatheter.
Rob,
and I'm going to ask Karema to select a new vessel.
Here.
Go ahead.
One more question, yeah. So after checking your first glue injection, relatively stable, would you consider doing additional branches without a tourniquet to have the flow help you to migrate the glue as distal as possible into the nidus?
Absolutely. I think that what we were trying to show here was whether or not there was going to be any benefit to the tourniquet. I can't tell you honestly that there was for that. It's a really good question that you asked, but I wasn't completely sure whether or not we were going to see flow go distally into the thumb, which I'm obviously trying to avoid. I think looking back on it, I probably didn't need the tourniquet. I think that is a good point. And I think we're going to look at the next branch that we inject with and without the tourniquet. We just may very well decide that we don't need it. And so those are all great technical questions. I think the tourniquet issue is just a good idea to just mention while we're trying to teach others that are watching this, and that is a great option to slow down the flow and have slightly better control about where the glue's going. Obviously, again, I don't mean to belabor this point. The glue did not go distally. It did not transport over to the venous side. We had no non-target embolization. So from that point of view, technically, it was a success. Would we have potentially better penetration or slightly more transport if we didn't have the tourniquet up? It's possible. But again, these cases are never straightforward, as you know so well. And it's a good idea to just be humble and sort of think outside the box with every injection you're thinking about doing.
Should we go more distal laterally, you think?
Yeah.
Yeah.
All right.
Two more.
Yeah, so the other thing, Rob, is just you sort of injected a little bit back from the nidus. You weren't like sort of wedging the catheter.
Correct.
Yeah.
I think if we were going to wedge it into the nidus, which sometimes I do, but in general I don't do that, I probably wouldn't have used such a dilute mixture because it likely would have led to much more reflux. In that instance, I think I injected total about 0.5 cc's, a little bit more than that. But it wasn't a full milliliter. So again, just relatively small volumes to allow us to get some penetration. And again, I can't emphasize this enough. The first injection is probably the most important one, just to get a gauge of what you're dealing with and whether or not you have more control or less control.
Yeah, I think when I tend to do these, I tend to pick my first target area tends to be small, and then I sort of work my way up from there, depending on how comfortable I am with the injection and where everything's going.
So we're just trying to find a good branch to get into to try and, again, set up the next injection.
It's pretty good.
Yeah, that was pretty good.
I actually like this.
Yeah.
Do you guys like this?
Yeah.
Yeah.
Okay.
Yeah.
I think we're going to go. Yeah. So let's take a picture with the tourniquet up. Can we get the tourniquet up again?
Yeah. I mean, the other thing is I did ask. Oh, sorry. Go ahead, Bulent.
I was going to say, just with the tourniquet up, tourniquet is very helpful. I like the way you're doing it, your first step, etc. I have seen a case that was presented somewhere. Someone did embolization with the tourniquet up, but they weren't as careful as you. Apparently, they were using alcohol and not seeing where it was going. They had a lot of reflux. So when people are using tourniquet, they need to be very careful, constantly visualizing where the embolic material is going. And if it's not visible, do not overdo it because it may have a side effect as well.
Yeah.
Okay, so here's the injection with the tourniquet up. And again, we can vote on whether or not we're going to leave it up or not. All right, what do you all think? Leave it up or take it down?
I would probably.
This is with the tourniquet up. This is with it up, and then let's go back to the previous run.
This is the previous one.
This is with it down.
One more time. Down, and this is up.
I would probably take it down. My personal opinion.
Okay, that's fine. Can we take it down? That's fine. Again, this is why we're all here, right? These are complicated cases, and we all respect each other's opinions. And I think it's all good to just be very humble and try to do the right thing for the patient and keep this safe. So the tourniquet's been down. I'm going to do another injection just to, again, confirm we're all happy with the flow dynamics here in about another 3-4 seconds. And so here's, again, another injection at the rate I was injecting before with the tourniquet down. All right. I'm pretty happy with this if you are all happy with it. Okay.
Looks great.
Let's get some
D5.
D5.
Yeah.
So again, D5 water is very important. You cannot flush the microcatheter with contrast because it's ionic. You want a non-ionic prep in the catheter to prevent early polymerization into the microcatheter, so that you can actually inject the liquid. This is absolutely critical to make sure that you are able to transport the liquid appropriately. Some people get a little OCD about how much they prep. I'm using a 3 cc medallion. I think that's more than enough.
Glue.
And I'm going to go straight to the glue here now. And again, we'll see where this goes. And everybody's watching. Here it goes with the glue.
So Bulent, while Rob is injecting here, you were mentioning the importance of visualizing your embolic and alcohol. When you're using alcohol, do you mix it a specific way? How do you track it?
Well, I usually do a negative roadmap, and then you can
So you can see the glue going forward, right?
Yep.
And it's transporting through.
Mm-hmm.
It looks like it's starting to get caught in the nidus, right? Like it's.
Yep.
There, that's good.
Yeah, that's very nice.
Yeah.
And I'm going to stop right there, okay? Because that crossing over vessel, I don't want that to go too far. And so I'm very happy with the penetration we got here. I think you all saw we got a lot of penetration, and it worked very, very well. So again, it's 8-1. I'm not concerned about gluing ourselves in here. I'm paying attention to the clock. I'm probably going to leave this in for at least another 30 seconds. And then take another sort of fluoroscopic image and make sure the glue hasn't changed significantly. And then we'll remove this microcatheter and then see where we can go.
Sorry, Bulent, back to you.
No, as I mentioned, I do use frequently contrast injection in between. I don't kind of overdo it. I do it with small aliquots, and then I do use negative roadmap to see the flow during alcohol injection. That's pretty much what I do. It's a lot more nerve-wracking. This is more fun and obviously very visible.
So nothing's dramatically moved, and I'm going to take out the microcatheter now. Again, I'm sort of pulling the lawnmower, so to speak. And here we go.
Do you
and the microcatheter's out.
Do you mix your alcohol with Lipiodol when you inject it, or you just do it as a...
Another micro, please.
Just save the syringe.
I sometimes mix it with Lipiodol in areas that visibility is even more important. If I'm in an area like deep area that I'm not concerned, I'm just trying to be effective, I use it just alcohol.
All right, and obviously you can see we are whittling away at this, okay? And this is the concept. We're going to try and do that. I think that other branch that's going into the thumb there, and see if we can wire that. And that, if I had to guess, will be our last injection of the morning. We'll work on that while we're chatting. But I think we've debulked this, probably by a minimum of 30%, maybe a little bit more. I think I like how devascularized it is. You can clearly see we've preserved perfusion to the digital arteries, which are very conspicuous here. But I think that you see that that target on the over the thumb is the next natural progression of where we want to be. So Bulent, since while we're getting set up, just as a sort of curiosity, when you're dealing with peripheral AVMs, do you have a prescriptive plan as to the frequency and the intensity that you bring patients back, with the understanding that, unless I'm way off base, we never feel like we've cured the patient in a single session.
I completely agree with you. I do a diagnostic angiogram like you did initially, and then depending on the flow pattern and I decide on if I'm going to approach percutaneously or transarterially, and I discuss all that with the patient. I usually tell them it's going to require more than one treatment session for complex ones. Sometimes you get something very simple and you can get away with one treatment if you're lucky. But usually, like this one is, for example, it looks small, but this is a very complicated. There are multiple feeders. A case like this is definitely going to require like more than one treatment, and patients know that at the beginning.
Yeah.
Do you err on every 2 weeks, every month, every 6 weeks? I'm genuinely curious.
I do like 2 to 4 weeks is what I tell them, depending on schedule availability. That way, like, obviously the contrast and radiation, if they may become an issue. Not in this case, obviously, but if we have a large thoracic AVM, there's a case that I show it in some meetings. I have used over 300 coils and 50 plugs and like, I don't know, 40 vials of Onyx. Uh, After 6, 7 sessions, it finally went away, and the patient's cardiac size actually went down 2 centimeters at the end of that process. It took about 6 months to do them all. So
Wow.
there's a spectrum, right? It's like so usually 2 to 4 weeks, but it may be a little longer, a little less, depending on patient as well as my schedule. I don't like to
Can
wait
we,
more.
can we have a new Fathom? Do you want a new Fathom?
No,
Okay.
I think we're good.
We're using a Fathom 14, if I didn't say that before. So to that, concept, I used to be, when I was younger, Bulin, a little bit more prescriptive about it, and I would tell the patients that they, had to come in at a certain time point, 2 weeks or 4 weeks. I think that, as you start to manage these patients longitudinally, which, we all do that, manage obviously any patient, but, certainly congenital vascular malformations are really important example of this, that you want to develop a relationship with them and you want to build up trust. And I would say that, more and more frequently now, the patients have a sense of trust. They recognize that we're, really trying to keep them safe. And I explained to them my preference would be to go as, rapid as possible, but I understand that might not be convenient for their family. They might have a moderate amount of pain after these procedures due to the post-embolization syndrome. And so I really ask them to just speak to us on a regular basis in the office, at least once a week, and keep the communication lines open. And then they should tell us when they want to come back. And sometimes it's every 3 weeks, sometimes it's every 5 or 6 weeks, but it's really trying to be patient-centric and patient-facing, understanding that, being more prescriptive, again, might not be in the patient's best interest. So that's I think one of the joys of taking care of patients with these very, very challenging problems, is allowing them to have a sense of autonomy in terms of their care and being able to dictate their schedule instead of only abiding by what I'm either writing down in my notes or what we're putting in the electronic medical record.
Couldn't agree more, Rob.
Can we take the tourniquet down, please? Not it. This is the other one, right? Yeah. Yeah, please.
Yeah, and especially when the symptom is pain, right? So if their pain gets better, and you don't necessarily need to bring them back so prescriptively,
You want the tourniquet up?
No.
Or down?
No.
We can leave the tourniquet down. Yeah, that's fine. Thank you. So the other thing is, should we get a different view, you know what I mean, to a different angle to be able to determine, because I do think that branch is going to be the last target for today, certainly.
So Rob, have you ever gone retrograde, coming from the vein to treat these AVMs?
Yeah, so it's a great question, Rahul, and I obviously know you and I have spoken about this before. It's I it's much easier, in my humble opinion, for the abdomen and for the pelvis. And I think the setup for those is just usually a little bit better managed that way. I have struggled, and Bulin, I'm just curious whether you've done this, and if you have, I'm really looking forward to hearing how you set it up. But I've struggled of how to set up a transvenous embolization in the actual hand. Do you do brachial vein access and go retrograde? Do you do femoral vein access? It's one of those things where I haven't found a setup that isn't unbelievably complicated from an ergonomic point of view. And as a result, I've just defaulted to these, transarterial approaches, especially in the hand or in the foot, that I think just allow me ergonomically to really feel we're doing a very, very safe procedure. It might be a little slower than some others, but again, safety here is the priority. And if we're setting up the room in a way that I think makes it a little bit more dangerous, I'm not sure that that's necessarily the right thing for the patient.
Right. We're currently reflexing.
I agree
So,
with you, Rob. I mean, I've done that in large ones in pelvis, etc., put a venous occlusion, amplats, etc., this and that. In this case, it would be very, I mean, can I say that it wouldn't be helpful? I don't know,
yeah.
but it would be probably a lot more headache than it would be helpful. Trying to, the higher you go, the more valves you're going to have to cross to find your way down there. And then getting into this retrograde, etc., prepping in the hand. I don't know if it'll be, it may benefit, but it'll be worth it. It'll just complicate things.
So yeah, I have to agree. In the hand, I've done it once and immediately regretted it because it was just hours of my life I wasn't going to get back. It's also super complicated to set up. I radiate my hands a lot to do it. I find if you stick the vein though in the forearm, the valves are all broken at that point, right? Because of the high flow AVM, there are no valves to manage. But you're swimming inside these massive veins, so trying to find a vein it can be tricky. The one that I did, we did a multiple arterial embolizations first, so to really knock it down, and then try to tackle it from the venous side. It's sort of like more of a finishing move than a way to start out the embolization. I think even in neuro, that's sort of how they do it as well. It's not their first go-to, but when they're getting towards the end of trying to fix the AVM is to do it then, because the veins just become easier to manage. Stuff. But I agree. In the periphery, in the abdomen, renal, I think it works great in renal. Mesenteric, like off the portal vein system, it seems to work well.
I'm gonna bring you back.
Pelvis can be tricky as well, but you can do it there. Yeah.
So as usually happens, I can't catheterize these small vessels, and Karema makes it looks easy and bails me out and makes the old man look like a doddering idiot. Exactly. So again, thank God for Karema as always. But I think we got into that vessel, or she got into that vessel that we were hoping to target here. So again, we're going to go through that exact same exercise we did before. And I really do think it's worthwhile talking about this. We're going to do an angiogram now without the tourniquet up, and then with the tourniquet up, and then we can vote on whether or not there's benefit of leaving the tourniquet up. Obviously, I don't like that, very high reflux right there, and so we might just say this is not where we want to be, and we want to go more distal, which we probably should. I think we have to get past that branch that's coming off horizontally. So we're going to do that before we take the tourniquet up. I think that's just a really good angiographic point here, is that if you identify it, it's not that this is the same analogy whatsoever, but when you do a selective injection of the uterine artery, and you see a cervicovaginal branch, you really don't want that to be in a acceptable non-target embolization. Obviously, this is the hand; it's very different. But to see an actual digital artery visualized, you don't want to compromise that. And so that was just a really nice example of, doing a good diagnostic angiogram and recognizing that, maybe this location isn't safe for the patient. And again, as usual, Krem is just doing an incredible job of getting past that branch so that we can hopefully do our last injection a little bit more safely.
Yeah, I mean, I think that this
Not
also
getting
sort of
stuck
lends
there.
to Bueland's
We
argument,
should
maybe
be
doing
past it, right?
to doing EVOH
think you're
instead,
past
because
it.
you have a little bit more control. Because once you start injecting, if you see that collateral start to fill, you can just sort of stop. With glue, obviously, once it starts to go, it goes, right? Like you can't always control it. You can't predictably control it. Yeah.
Still.
Yeah, still there. So
Yeah.
I think we have to get past that
See,
turn.
there's a little bit of a
Spasm.
there.
Yep.
The catheter's not going. Okay.
That's a very sharp
Then we
turn
have
too.
Yeah.
Yeah.
You have the Fathom wire. Do you ever use more sophisticated neuro wires when the Fathom is?
So that's a great question. So we're using a 14 thousandths wire. I personally, I don't mean any disrespect to anybody. I've not noticed a significant difference between the Fathom 14 and a Synchro, just as an example. We could go down to a 10 thousandths wire. But since you brought it up, Yulin, I'm just, curious, do you have a specific wire that you would prefer here that you think would be beneficial? Now, again, I think Karem has gotten through the loop. I think we just need to navigate it. It might need to be that we need to admit we need a different microcatheter, and that's fine also. But I don't believe the wire is the issue right now.
No, the wire actually got very close. The microcatheter maybe like again, smaller microcatheter may help in some of these cases, and that's kind of the worst thing to do, to exchange a microcatheter.
Yeah, all that work.
I would try my best.
Do you think we should get a new microcatheter?
Well, the issue is the Fathom 14 has a really long floppy tip, right? So I don't have any. The wire's going fine. It's stopping here. I'm trying to twiddle it forward, but it's really not. We can advance our base.
Would you give a nitro?
So the other question is, should we give a little nitro to get rid of that? Here.
The nitro is a good idea. We could do that.
It's just a catheter. It's kind of getting stuck.
All right, so let's take out the wire. We can give a cocktail into the into this branch. So we're going to give a standard radial cocktail. It's just something that we use obviously every single day, but it's nitroglycerin, verapamil, a little bit of heparin. Now that obviously looks a little bit better now.
Probably because
the
the spasm.
The spasm's probably helping you at this point.
Yeah, exactly.
Yeah.
So maybe.
I think we still give the vasodilators because I'm a little bit worried about reflux here because of the distal spasm.
What do we have here?
This is verapamil, nitro, and heparin.
Full cocktail. He just said that. Yeah.
So again, we're giving nitro now. Always communicating with our anesthesia partners, and verapamil and a little bit of heparin. And we're going to give that about 60 seconds to go in, and then we'll repeat the angiogram and see if it changes. How are we doing on time?
You're good. You're good. Yeah.
Okay.
You still have about like 10, 15 minutes. So.
All right, great. Okay. So again, I think if we can get a position to do this injection to a final angiogram, that's a really good session for this patient.
Can I get a flush, please?
Yep.
Bueland, when you're doing these cases, pain management afterwards, how do you take care of them? NSAIDs, narcotics, steroids. What are you doing?
Most of the time, narcotics, steroids as well, depending on the size. If I'm worried about inflammation, with alcohol and glue, usually they help. If I use EVOH, I don't use steroids as much. And
nitro.
But pretty much all of them get a 3 course of narcotics at home after making sure that their pain is controlled with oral, that they get discharged. I usually reserve an overnight bed for them just in case if it's
think
really
the
painful area. And every patient is different, every lesion is different. I would say 1 in 10 patient will have difficult pain control. Most of them are relatively straightforward.
Yeah.
Yeah.
I think the nitro changes.
So, what we were just sort of chatting about offline is that we're seeing that distal tuft vessel in the thumb show up now, which I think you both see very clearly, right? And I'm a little worried about losing that. And I think in the spirit of being safe, I'm not sure that we should keep. I certainly don't think we should inject here. Let me leave it
Yeah.
at that. And I think what we're probably going to do, because I do think that's coming off of the screen at about 6 o'clock. I think we sort of need to admit that this microcatheter is not going to go, and that we need to trade out a different microcatheter. I do want to try and explore getting down into that vertebral segment and into that lateral branch that's going almost
Another
into her
014?
nail bed. And see if we can do that and then do the last injection here. But that's probably going to take us well beyond the time that we have left. And so, again, I just want to make sure that you both agree that this is probably not a safe place to inject. And then if there's any questions that you both have, and if not, we can obviously wrap it up.
Yeah, I agree. I think
Completely.
this is agree. Yeah.
Yeah, I would get more distal and this smaller microcatheter, just like you said, because if you take those turns, which is not going to be easy with this catheter, probably not possible, it'll be very safe to treat the rest and more effectively.
Yeah.
I couldn't agree more. Since we have you both, Bulent, do you have a preferred microcatheter? Again, this is a True Select. It's a pretty sophisticated, elegant microcatheter. We're obviously going to escalate into the neurointerventional territory, but just to throw out a couple of names so that we're just trying to help people that are watching from home. What would you go to next?
I use the Echelon 14. Probably in this case, it's probably smaller profile than this, and you can use like again. I know you don't find a difference. I do like to use not the regular synchro, but the synchro soft to take out multiple like this, and then maybe a headliner catheter every now and then may also get you further down. Even though that Fathom was impressive already, so you may stick with the same one too, because the catheter was the primary problem, not the wire.
Yeah, again, this is an 021 catheter, microcatheter, so I think we're gonna de-escalate significantly and probably go down to a 014 catheter and an 010 wire. And I like the Synchro 10. I think certainly a Synchro 10 is a different wire than the Fathom 14. And again, I like the Echelon. There are a couple of other catheters I want to see if I can try also. Serenovis makes some nice catheters. But again, I'm going to probably close it out in just a second and then go down to our neuro colleagues and pull some equipment. So on that note, I just want to thank everybody for joining us this morning. I want to thank everybody here in the room. I want to thank Karema for bailing me out and making it look easy as she always does. David for a great presentation. Mike for the help on the back table. Everybody from anesthesia, the nurses, and again, thank God for our techs. It's Tech Week, and we love all of our techs here. Best techs in the world we have here at Mount Sinai IR. Broadmed AV, again, thank you so much for everything. Bulent, my dear friend, thank you so much for helping us this morning. And Rahul, as always, thank you for co-moderating. And on that note, I'm going to sign off, and we'll see you all next month.
Thanks, guys.
Thank you very much.
Thanks for joining.